I have tried to tailor my talk for nephrologist point of view, and please keep that in mind when you are going through my slides. At the start, I will just in one slide, I would like to summarize about the proton pump inhibitor, that they are the chemically weak bases and bench imidazoles. If you see the parietal cells which secrete acids in stomach, acetylcholine, histamine, and gastrin, they act as stimulant at the basolateral part of the cell, and they stimulate acid secretion finally through hydrogen potassium ATPase, which is a P type of ATPase. And proton pump inhibitor acts in the final step of acid secretion, and that is why it is considered to be a very strong inhibitor of acid secretion as compared to syntapride, H2 inhibitor, H2RA. These are weak bases, and that is why they are trapped inside the parietal cell canaliculi, and they reach a concentration of more than 1,000 times as compared to blood drug concentration. After being trapped inside the caniculi, they are activated and they covalently bind with the proton pump. And because of their covalent bonding with the proton pump's hydrogen potassium ATPase, their activity is prolonged, and a single daily uh, dose administration in morning inhibits roughly 66% of acid pump, and acid suppression can continue for 48 hours. This is the basic concept about all the proton pump inhibitor, whether it is omeprazole, pantoprazole, lansoprazole, or any other drug. Their difference in pharmacokinetics, their efficacy, extent of acid suppression, duration of acid suppression, it is primarily determined by their concentration achieved in the canaliculi, as well as by their selective binding with the cysteine residue on hydrogen potassium ATPase. Now I'm coming to the topic of indication of PPI. These are the hardcore indication of use of proton pump inhibitor: gastroesophageal reflux disease, peptic ulcer disease, ulcer-related bleed, and dyspepsia. Among these, dyspepsia is the most common indication for use of PPI across the board, across the specialty and countries. And patients with chronic kidney disease, especially those on maintenance hemodialysis, are more likely to have upper GI symptom in form of dyspepsia, bloating, heaviness, postprandial heaviness, all these things, to some extent GRD also, H. pylori infections. So this study, which has measured the GI symptom rating score in different group of population as compared to control, hemodialysis population, peritoneal dialysis population, and pre-dialysis chronic kidney disease, and found that prevalence was higher in patients with chronic kidney disease. But I would like to emphasize here, it is generally accepted and practiced also, but as of now, data on the prevalence of upper GI symptom and use of PPI in chronic kidney disease are controversial. There are some studies which suggest that the prevalence are not different, but the prescription of PPI are higher in patients with chronic kidney disease. Why this dyspeptic symptom or upper GI symptom in chronic kidney disease are more? There could be some explanation which literature suggests. The patients with chronic kidney disease, because of the lots of toxins and uremia and other metabolites circulating in their blood, the gastric emptying is slowed. This is well established. Lots of studies have shown their gastric emptying time is prolonged as compared to healthy controls. They have serum gastrin level which is increased, and this gastrin act as a stimulant for acid secretion which can cause dyspepsia. But again, and which gastrin is increased, whether this increased gastrin is translated into increased acid production is again a controversial issue, because There are two types of gastrin. One is G17, which is a smaller form, and the larger form is G34. G17 is 6 times more potent than 34, and the level of G34 is found to be elevated in patients with chronic kidney disease because it is cleared by the kidney, and if the kidney is not working normal, so gastrin level is likely to be increased. The third cause which is assumed is presence of hyperammonemia overall in the body, which is secreted in gastric juice also, which is neutralized by gastric acid. So as a reflex, body need more acid production to neutralize the hyperammonemia, which is the inherent condition in chronic kidney disease. So when we are using PPI, it can cause lots of adverse effect on long-term use, which are very well known. Lots of is talk about reduced bone mineral density, which causes fracture. So especially those who are predisposed for bone dystrophy, like chronic kidney disease patient, chronic liver disease patient, they are at higher risk for developing fracture. PPI use causes atrophy of the acid producing cell and can predispose for gastric cancer. It also predisposes several infections, especially Clostridium difficile infection, which causes pseudomembranous colitis, antibiotic associated diarrhea, other bacterial infections, small intestinal bacterial overgrowth, microscopic colitis. This is assumed to be related to the effect of PPI on gut flora. It inhibits the gut flora, changes the gut flora, and the production of short chain fatty acids are reduced in the colonic lumen. These short chain fatty acids act as a nutrient source of nutrition for colonocytes, and in absence of these short chain fatty acid, microscopic colitis may develop. But these are all assumption, it's not proven. Ultimately, what is sure is that long-term use of PPI causes gut dysbiosis, and I will focus only on gut dysbiosis. This PPI is intended to use to inhibit acid secretion from oxygenating cell or parietal cell from stomach, but they also act on other cells or microbes in the body which have P type of ATPase enzyme. The very commonly known bacteria and fungus like Helicobacter pylori, Streptococcus pneumoniae, Candida, Cryptococcus, Aspergillus, they are known to have P-type ATPase enzyme, and these PPI act on them also, which can have a inhibitory effect on them or a supportive effect which increases their proliferation. And you can see that that is why H. pylori infection is found to be associated with PPI use in patients with chronic kidney disease, high risk of pneumonia, Clostridium difficile leading to antibiotic-associated diarrhea or pseudomembranous colitis, fungal infection. These bacteria, which have P type of ATPase enzyme, they predominantly live in as commensal in oral cavity in upper respiratory tract. So when the PPI use for prolonged period of time, these bacteria may proliferate and may change the dysbiosis in human. How this PPI will affect the gut flora? The possible explanation could be it reduces the diversity in the gut microbe. This is well established, shown in multiple studies. I have not quoted any one because there are n number of studies in different group of population: chronic kidney disease, chronic liver disease, healthy population, uh, in rheumatoid arthritis, autoimmune conditions, n number of conditions where the gut flora has been examined and found that PPI reduces the diversity of the gut microbe. It changes the relative abundance of the bacteria in a given person. Means the proportion of different bacteria which are present in equilibrium are changed. They reduces the abundance of the gut commensals, meaning good bacteria, enhances the abundance of the pathogenic bacteria, increases the abundance of oral cavity bacteria. In summary, you can say there is oralization of the gut microbiome PPI users. Just few study I will like to quote to support my statements. The very good study from Japan. It's a case control study. The 32 patients who have used PPI for a minimum of 1 year regularly and 32 control, which were age and gender matched, they have not used PPI for more than 5 years. Their stool samples were compared. And we can see all the 3 parameters of alpha diversity were reduced in those who have used PPI. This is a very important study which was published in 2015, where the healthy volunteers, 12 healthy volunteers were taken and they were given PPI. The stool samples were collected before starting PPI, after 4 weeks of PPI, and after giving 4 weeks of PPI, they were randomized in 2 groups. One group continued to take PPI and another group stopped PPI. And then the follow-up stool sample was collected after 4 weeks. This study has shown that overall, with the 4 to 8 weeks of PPI use, the gut flora has not changed markedly. But the taxa which are associated with Clostridium difficile infection or associated with upper GI bacterial overgrowth, they were overrepresented even with this much short duration of PPI. And we know that even for dyspepsia, for H. pylori, suspected H. pylori infection, it is very common practice to prescribe PPI for 4 to 8 weeks or 3 months. So even a short duration of PPI can change certain classes of gut flora in a healthy person. How this PPI affects the gut flora? Most likely it reduces the gastric acid production, which act as a first line of defense in our body from uh, inhibiting the pathogens which are entering through oral route with food. And if acid is reduced, they can easily colonize our lumen. Change in pH may induce a change in microbial composition, which are normally present in the lumen, because every pathogen is comfortable in proliferation and a certain pH. If pH is changed in the lumen, the microbial preference may also change. Reduced pH will promote the growth of pathogenic bacteria. Because of change in pH, the nutrient milieu of the intestine may also change, which may alter the proliferation of commensal bacteria or the pathogenic bacteria. All these things has been discussed by our 2 previous speaker, so I need not to elaborate on them. And as Dr. Vikas has told, that bacteria are very intimately associated with mucosal immune system. They prime them, train them, induce them. So whenever there is use of PPI, pH is changed, different bacteria is coming, immune system is altered. And if immune system is altered in one place, it may affect the gut flora composition in different places. Now I'm coming to the prebiotic and the probiotics. WHO defined probiotic as a live microorganism, which when administered in adequate amount confers a health benefit on the host. So this is a standard definition. And probiotics are most commonly used is the inulin or its product and the galactolygosaccharides. What is an ideal probiotic? An ideal probiotic should have all these characteristics before it should be labeled as probiotic. It should be the organism should be non-pathogenic. It should be resistant to acid and bile because they are normally present in our gut. So if probiotic is given orally and it is not acid resistant, the bacteria will be killed in the stomach or in duodenum. It should be effectively adhering to the gut lining, Short generation time means it should proliferate fast because the number of bacteria we are giving are not sufficient enough to replace the amount of bacteria present in the lumen as told by Dr. Narayan. So they have to proliferate. These bacteria have to survive the robust and the surviving process and the processing of the capsule formation of the preparation because they're prepared under astringent conditions. They should not create or do induce any mutations in the host. They should be genetically stable. Means once they have started proliferating inside the lumen, they should not be changing in their genetic content, which can induce antibiotic resistance, which can induce bacteremia, pathogenesis, sepsis, etc. And it is preferable if they produce the lactic acid to create the acidic environment. Some of the commonly used probiotic microorganisms as bacteria, yeast, and spore of bacteria are listed here, just to complete the list. How they give benefit to the host. The most common mechanism is the enhancement of the epithelial barrier system. They adhere with the gut mucosa. They induces the production of protective mechanisms such as mucus, defensin, bactericin, immunoglobulin A, and other defensive mechanisms which are inherently present in our mucosal lining. They also inhibit the pathogenic bacteria which are present to adhere with the lumen. Uh, if the pathogenic bacteria is not adhering with the receptors present on the gut lining, they are unlikely to produce any direct toxic effect or pathogen. So they inhibit their adhesion by competitive mechanism and also directly inhibit them by producing bactericid. As we have learned, they induce and modulate the immune system. You can see here some of the effects, some of the plausible mechanism for gut flora action will occur with a short duration of use. And when they have to act through the immune system, they are likely to be taken for longer duration. So most of the probiotics which are used in clinical settings, there are four group of condition. One is prevention of disease, treatment of disease, treatment of acute condition, treatment of chronic condition, and prevention of drug side effect. For acute conditions, that's why we have to use probiotic for shorter duration. But whenever we are using it for prevention or treatment of the chronic diseases, then it is most likely mediated through the immune system. And then we need administration of probiotic for longer duration, say 3 months, 6 months, or for years, which is not known. So these are the few well-established indications of prebiotics and the probiotics. Otherwise, prebiotics and probiotics are used in any conditions, but some of the established condition I have established here, I have enumerated here: antibiotic associated diarrhea, traveler's diarrhea, Helicobacter pylori treatment. Primarily, the evidence in support of H. pylori treatment with probiotic is it helps the patient to complete the therapy. It helps in eradication, reduces the side effect in treatment of irritable bowel syndrome and acute gastroenteritis. So the question for a physician is what dose, frequency, duration, and which probiotic? Unfortunately, there is no universally accepted guideline that which one is to choose, how frequently to use, and for what duration. British Society of Gastroenterology, Italian Society, Brazilian Society have laid some guideline, which I have summarized here. That daily we have to give 8 to 10 to the 10 to the power 10 colony forming unit. Roughly, at least 1 billion colony forming unit has to be given daily. So maximum daily dose should be 1 to 10 billion CFU. And just to recapitulate, the most known brand VSL3 has 112 billion colony forming unit in one capsule. It has to be divided into 2 to 3 doses, and duration, as we have just discussed, that in acute illness usually it should be short, 7 to 10 days, but chronic condition at least 4 to 8 weeks, even longer can be considered, because all this information is based on the trials, and trials cannot run for years. Most of the trials have tried for 4 week, 8 or 12 weeks. That's why I'm writing that for chronic conditions, it has to be used for 4 to 8 weeks. So when you are selecting a probiotic among the various brands available in the market, we have to take care of few things, whether we need a bacterial or a fungal one. The general concept is, when you feel that the disease pathogen is a bacteria, then we have to prefer basically a fungal uh, probiotic. If we feel that the pathogen is virus, then we have to prefer a bacterial agent. But it is not a hard and fast rule. It is just a generalization, a simple understanding. We have to see the number of colony forming units which are viably present in a given dose, and obviously the storage condition, requirement of the storage condition, and signal on the multiple strain. In general, it is accepted that multiple strain containing probiotic work better as compared to single strain containing probiotics. Then the dose of prebiotic, again, we don't know. It has to be given daily, and it has to be given with probiotics in divided doses with every meal, especially when you are giving probiotics. So most of the time you are getting pre and probiotic in combination in the market, so your problem is sorted out. And dose is 4 to 20 grams per day. In summary, upper GI symptoms are likely to be more common in patients with chronic kidney disease. And for these symptoms, if needed, PPI shall be prescribed, preferably for a short duration of period. Short-term use of PPI does not markedly affect the gut flora, but long-term use of PPI have multiple adverse effects. Many of these adverse effects are mediated through change in gut flora. Supplemental use of pro and prebiotic may restore the gut flora. Thank you.